Okay, so here we go with the next part. The hot and cold modalities, there's a PowerPoint there. I'd like you to just kind of look through that, make sure you have it down pat, because I'll be expecting that you're going to use the hot and cold modalities and to use them correctly around this idea of acute and chronic on your cases on the midterm. So go through that, ask me if you have any questions on that. Some of it's review, but again, applying it to the cases real specifically probably isn't review. Make sure you got that down. There's some serious points on the midterm. So review that on your own and then ask questions on that. Okay, so now I want you to pull up that treatment box for the frozen shoulders and osteoarthritis and all the stuff we've been talking about here. Okay, so here is the arthritic shoulder. I'm not going to go into that in depth. It's all there. It's not gray, so it's a resource for arthritic shoulders. They're pretty basic in your treatment. Total shoulder replacements. These are some general protocols. You'll get protocols from the orthopedic surgeon as well on what to do over the time period when you're rehabbing a shoulder replacement. You'll see a lot of these in different settings. And then this is the big thing for this week that you need to know and need to know well. Adhesive capsulitis. Again, there is no test for adhesive capsulitis. How do you know that they have adhesive capsulitis? There's certain questions you can ask that really kind of key you in, whether it is adhesive capsulitis or not. Are they going through those stages? Is there no history of known trauma to the shoulder? No known history of known trauma to the shoulder, where you can't really link it up to a job where they're, putting the shoulder in a compromised position. Start to think, this could be adhesive capsulitis. It's getting progressively stiffer. It's very painful, getting to the point where they have no motion at all in that shoulder. I'm thinking of adhesive capsulitis. Another key clue, the active range of motion and the passive range of motion are close to the same. Let me repeat that. The active and passive range of motion are similar. If you check out the video that they do there, he was classic. His active and passive are the same. You cannot really move him significantly more than what he could do actively. The strength is intact with frozen shoulder, very unique frozen shoulder with the frozen shoulder. They have no limitations in strength. When you do your manual muscle testing, pushing all those planes, they're very painful, but they're very solid. And then these are the different stages. These are kind of questions that might clue you in to get at what stage they're at. Does it hurt? All the time is usually stage one. Is it comfortable? Stage one. I'm not going to go through them, but they're all kind of there. Talks about the surgical interventions. And then how do you treat it? Those early stages. Limited potential. You can start to range it as they did in that clinic. Pendulums are good. Some dowel exercises you could do, especially when they're hitting 6 months or so. One-handed stuff, they're going to have to learn how to do stuff one-handed. Heating it up is usually good. It's kind of a chronic thing, even though it's could be a early, less than 3 months. It's kind of really chronic. You're kind of heating it up, and then once it starts to thaw out, you're hitting 6 to 9 months. 9 months especially, you really need to go to town on it. You really need to stretch it hard. Be very, very aggressive. How much pain the patient can tolerate is kind of what's your only limits. Generally, you're going to heat it up, heat or it's ultrasound, and you're going to stretch very aggressively. Trigger point releases, especially that bicep insertion, the short of the bicep when it comes up under your armpit. That's a good one if you can release that. I've had good return on people's shoulder. Trying to get that rotational stuff, the abduction stuff. And if you look down here, this is kind of the down and dirty. It summarizes that adhesive capsulitis rehab really well, generally. These are evidence-based exercises that are good for regaining the motion in the shoulder. None of them are rocket science, kind of what you would think you would do. These are the wand exercises he's doing. The pendulum, the pulley that we talked about earlier. Cane is forcing it up into external rotation. And some joint mobilizations that we will do in lab. some of these joint mobilizations. They can respond really well to joint mobilizations, especially in the latter stages. That's another key tool to have in your toolbox with adhesive capsulitis. So that is the adhesive capsulitis. So let's go back to the PowerPoint, to our case. Back to old Batman. So what do we think he has? It's kind of obvious. It should be obvious at this point that he has a frozen shoulder. It's starting to, so it's been 9 months and it's starting to loosen up. Those are good signs. So okay, he's a prime candidate for therapy. You can really kind of go after it. Aggressive range of motion, using the wand, heating him up, different planes. He would be a good candidate for all that stuff we just talked about in the treatment box. Learning objectives revisited. How do you assess and treat adhesive capsulitis in the freezing stage? Symptom management, one-handed dressing, modalities, try some pendulums. Could try some ranging, depending on what they can tolerate, to get for results. How do you treat adhesive capsulitis in the thawing stage? Just talked about that. That's when you're really, really aggressive. We go to that treatment box. Contraindications for using ice, contraindications for using heat. Go to that PowerPoint, it will tell you that. What do you need to know those, especially for the midterm? How would you generally treat a shoulder replacement 6 weeks post-surgery? Again, go to that treatment box. It'll tell you what 2 clinical presentations would help you determine if someone has a frozen shoulder. There's active range of motion and passive range of motion is the same. Their strength is relatively intact. It really isn't impaired. And then what is coming up? No quiz this week. Student-led demonstration, shoulder and the scapula. We're up to that. Okay.